We've been talking about for years about me wanting to come and visit CSU and the center here, and it's been a real treat. It's really an amazing facility, the Orthopedic Research Laboratories, and then the hospital and the equine facilities. It's really phenomenal from a clinical and research perspective, so very impressive. Wayne and I thought it might be good to talk about OCD, osteochondritis dissecans of the knee, and a little bit about deformity. And so that's what I would like to do this morning. And my disclosures are shown here. I don't think there's anything specifically conflicting with what I'm going to show in this talk. And again, it's been something that we've been talking about, trying to come and visit and see what goes on here, both in terms of research and clinical care. And I think there's a lot of parallels. You know, I think as a equine surgeon and as a sports medicine orthopedic surgeon in humans, we've had a lot of overlap when we're talking about research and also clinical conditions at our scientific advisory board meetings. You know, I think as a orthopedic surgeon that does sports medicine in kids, I'm always getting asked by people about their kids' injuries, and these are our sheep and our horse, and so I'm sure you guys get asked about people's pets and their animal injuries as well. I think we deal with a lot of athletes that are doing high-impact repetitive sports at a young age, and you're seeing that as well in your athletes. We see injured athletes who we treat non-operatively or we treat operatively, and then some of the conditions are actually very similar. So OCD, osteochondritis dissecans of the knee, which I'll talk about today, and osteochondrosis, which you see. So for me, it's really exciting to think about this overlap between human orthopedic surgery and veterinary orthopedic surgery. And I think there's clearly a lot of overlap in research. You know, the work that you do with cartilage research, stem cell research, there's a lot of overlap. This is some work that's going on in our labs with Martha Murray, who's looking at bioenhanced repair of the ACL instead of reconstruction in a pig model. And then that translational research to humans, I think, is an area clearly of overlap. It's also interesting to think of the clinical areas where there's overlap as well. And so when I hear of what's going on in veterinary sports medicine in terms of stem cell injections, which we don't really have in humans yet, you know, early use of glucosamine, management of stress fractures, differences in treatment of ACL injuries, and regulating training in terms of prevention of injuries, I think there's a lot of clinical potential application for our human patients as well. So specifically, I was going to talk about OCD, osteochondritis dissecans of the human knee, and then some ways we manage deformity as well in our pediatric population. So we'll start with, I wanted to give you just a sense a little bit of what we're seeing in pediatric sports medicine. And so I work at Children's Hospital Boston. I'm a pediatric orthopedic surgeon, also do sports medicine. We have a sports medicine division where we have 7 orthopedic surgeons. We have 12 primary care sports medicine physicians, 2 sports podiatrists. We have sports psychologists, sports nutritionists, and that's just all pediatric sports medicine within an overall orthopedic department of 28 pediatric orthopedic surgeons. And we're such a big program because I think we're starting to see so many injuries in children and adolescents. And we know when a professional athlete goes down with a major injury, the issue that we're seeing is we're starting to see these more major injuries in our younger patients. So this middle school girls soccer team on the left can look forward to growing up, becoming this high school we take care of, nearly half of whom have torn their ACL and have had ACL surgery. And this is a hot area. I think within medicine, injuries in sports and kids and adolescents is a hot area. We certainly are interested in pediatric orthopedics and in sports medicine. It's a big area in general orthopedics and in pediatrics, internal medicine, athletic training, and exercise physiology. It also has received attention in the lay press. This was the front page of the San Francisco Chronicle, talking about growing pains, children's sports injuries getting worse. This was in the Boston Globe, a patient of ours rehabbing after a knee injury. This was the front page of the New York Times with a big-time injury striking little players' knees, a patient of mine from Texas with ACL surgery. And then this was last year on the ABC World News with Diane Sawyer, and this was a little 8-year-old patient who had done ACL surgery on, and they talked about, this segment was on ACL injuries in kids, and he ended up getting to meet his hero, Tom Brady, who had actually had ACL surgery as well. And it's a bit of a paradox because really in pediatrics we know that there's an epidemic of childhood obesity, and this has major public health implications for us in the future. But those of us that are seeing sports injuries are also seeing an epidemic of sports injuries. And so it may be that our youth are getting very polarized, on one hand to underactivity, on the other hand perhaps overactivity. And if we look at the numbers for youth sports injuries in the US, they're very high. So over 30 million children and adolescents are participating in youth sports. More than 3.5 million children, if you just looked 14 and under, are receiving medical treatment for sports injuries. And if we looked at 5 to 14-year-olds, they're accounting for almost half of all sports-related injuries seen in emergency rooms. And the context is really that youth sports has changed. So kids are playing less free play. They're playing high-intensity sports at a younger and younger age. They're focusing on a single sport instead of participating in multiple sports. There's lots of involvement of adults, and youth sports has certainly become a big business. And so, you know, LeBron James, his games in high school were televised across the country. This is a professional tennis player at the age of 10 in Europe. Freddie Adu had a Nike contract at the age of 14. And so youth sports is really a big business. But before we trash youth sports, we really need to remember the benefits of youth exercise. So medically, decreased obesity, diabetes, better cardiovascular health, better bone health, and probably more importantly, psychosocially. So adolescent athletes have a higher self-esteem, less likely to have teen pregnancy, recreational drug use, and better career success later in life. So the challenge for us is really, how do we get these benefits of youth sports while trying to avoid the injuries? And this represents a change in approach. The dogma in traditional pediatric orthopedics would have been that kids didn't get major knee injuries. You really could cast them and they would heal almost all their injuries. They're not tearing their ACL. And so those things that were written in the textbooks we know have changed because we're seeing decreased injuries, greater severity at a younger age. And we really need to think about the long-term consequences. So we see meniscus, cartilage, ligament injuries in kids. You know, what are they going to be like 10 to 20 years down the road in terms of their risk of arthritis, dysfunction? How's it going to affect their ability to work, everyday activities, and their health-related quality of life? So we say, you know, in pediatrics, they say a child's not a little adult. And so in pediatric adolescent sports medicine, we try to make the point that the child athlete's not a little adult athlete. So with that kind of background in pediatric sports medicine, and the number of injuries that we're seeing, I'm going to talk next about OCD of the knee. And OCD of the knee really has changed in our management. Again, traditionally in pediatric orthopedics, OCD of the knee would be treated non-operatively for extended periods of time. So this is actually pictures from Green and Banks at our institution, 1960s, where OCD would be treated in this brace where you bypass the knee, and the child would be in this for about 2 years for OCD to heal. Be a challenge to get a child to wear that now. And when it came to surgery, it was open, so it was arthrotomy and largely involved removal of the OCD fragment without any chondral resurfacing, which would lead to arthritis down the road. So what are we seeing now? I think we see OCD more frequently. We see it in younger patients, in females as well. We have better ways of imaging OCD with MRI, and we have arthroscopic ways of treating OCD. What I'll do is talk a little bit about etiology, our diagnosis, treatment, and give you some thoughts in conclusion. I think in the humans as well, there's a lot of confusion about terminology. And so when we're talking about osteochondritis dissecans in the human, what we're really talking about is a chronic, not an acute condition that predominantly involves the subchondral bone, secondarily the articular cartilage, and can lead to separation of that osteochondral fragment. And the overlap is with an osteochondral fracture, which does involve bone and cartilage but is more acute. A chondral injury, whether that's acute or chronic, which is involving cartilage and not bone. Osteonecrosis, which is avascular necrosis of bone, which also can lead to bone and cartilage fragments. Osteochondrosis, which is a term that you use a lot, for us, which would probably include OCD, but other conditions involving bone and cartilage, including apophyseal cartilage. Accessory centers of ossification, and then there are variants of skeletal dysplasia, particularly multiple epiphyseal dysplasia, that have osteochondral-like appearance with multiple lesions, and so there's a lot of overlap. The etiology, Koenig gave us this term osteochondritis dissecans in the 1800s, implying inflammation, but probably primary inflammation is not the etiology of OCD. We typically see this with repetitive trauma, and we don't see OCD frequently in kids that are not as active. It's debatable whether there's a relative area of ischemia in the areas where we see OCD. So the lateral aspect of the medial femoral condyle in the knee joint, the talus in the ankle joint, and the capitellum in the elbow joint. Again, it can look like ossification variants. We have a lesion of the lateral femoral condyle, usually in younger children that aren't that active, that is often overcalled as an OCD that we think is just an ossification variant because it's typically incidentally found. It's asymptomatic and it resolves on its own without treatment. That sounds very similar to what Wayne was dealing with this morning in the medial femoral condyle and quarter horses. And we do have families in which OCD runs in the family, and we can see it with certain endocrinopathies. A diagnosis of OCD, our epidemiological numbers are old, and so we're getting better numbers now from Scandinavia, but the prevalence has increased. We're seeing it in younger patients. Our OCD prevalence at Children's Hospital in Boston is almost 1-to-1 male to female now, and it's often bilateral in the knee, and the knee being the most common location. We also see OCD in the ankle, the talus bone, and OCD in the elbow, particularly in throwers and in gymnasts who are weight-bearing on their arm, and the capitellum, the lateral elbow. The history and physical examination depends a lot on the stage of OCD. So if it's an early stage lesion with intact articular cartilage, the symptoms may be very vague, just vague pain and stiffness. We may think it's sort of typical patellofemoral type of pain, which is a very common thing that we see. If there is instability of the bone and cartilage fragment, now you've got more obvious symptoms like catching, locking, swelling in the knee. Our patients may walk with an external rotation gait because the most common location of OCD is the lateral aspect of the medial femoral condyle. This is the ACL inserting towards the tibial spine, the anterior tibial spine. And with internal rotation of the tibia, the spine may abut the medial femoral condyle, and that's maybe why these patients walk with an external rotation gait. We get radiographs. This radiograph is very important, which we call the notch radiograph. It's an AP radiograph of the knee in some flexion. If you take an AP radiograph of the knee in extension, you may miss the lesion. So not a lot going on here, but in flexion you can see this lesion. Same thing here, maybe a little line here in extension, but in flexion you can see the OCD lesion. And that's because many of these lesions live more posteriorly on the femoral condyle. In an AP X-ray, you can miss the lesion. We can classify OCD based on its location on X-rays. There's also a classification based on its stability as well. We use these largely for research purposes. Bone scan was very popular in the 1980s, and Cahill, who was an orthopedic surgeon in Chicago, was a big proponent of bone scan. And bone scan does give us more information than X-ray. It gives us some sense of blood flow and osteocyte activity. And the features on bone scan were prognostic of whether OCD would heal with non-operative treatment. And there was a classification of OCD based on bone scan. But by and by, bone scan's been replaced with MRI, so we don't use bone scan very much. So for us, almost every patient we see initially we evaluate with an MRI, and most of them will come in with an MRI. An MRI can give us lots of information about OCD. It can give us information about the articular cartilage, whether it's intact or not. What's the stability of the lesion? So is there fluid or displacement of the lesion, fluid behind the lesion? How much edema is there in the underlying bone? We found it to be very sensitive and specific in terms of diagnosing OCD, and some of the features on MRI are predictive as to whether it will heal or not. The most common MRI classification we use for OCD is the Hefty classification from Basel, Switzerland, where stage 1 is intact cartilage, but it's not well marginated. Stage 2 is intact cartilage, but it is well marginated. Stage 3 has a fissure or a crack in the articular cartilage. Stage 4 is unstable but in situ, and stage 5 is a loose fragment in the knee. So here's some examples. This is an AP radiograph with a coronal MRI. And this is a stage 2 lesion, so the cartilage is intact, but it's well demarcated and there's edema behind the lesion. This is a lateral knee radiograph and a sagittal MRI, and this would be a stage 3 lesion where there's fissuring of the articular cartilage and offset of the articular cartilage, but not gross instability or a free fragment. We're very interested in MRI, so see these are some of the other features that we're looking at in MRI in terms of the OCD lesion, characterizing it and which lesions may heal non-operatively or operatively, which lesions we need to be more aggressive with based on how they appear on MRI. So some of the things that we're looking at are the contour of the articular cartilage, whether it's normal or whether it's offset in a concave or a convex type of direction. We're interested in the interface between the articular cartilage and the bone of the lesion itself. And so is there increased signal? Is it linear or is it more diffuse? And so that's the signal between the articular cartilage and the bone of the OCD lesion. We're looking at the interface between the bone of the OCD lesion and the underlying progeny bone of the condyle, whether that has increased signal, whether there's cystic changes, how irregular that is. We're interested in the bone fragment itself. How big is it? What's the quality of that bone? Is it fragmented? So we can get information on MRI on this as well. We're interested in the bone marrow. So is there bone marrow edema? If there is, how diffuse is it? What kind of pattern is it? And so we're looking into these features as well. And our goal here is to try to understand the lesions better so we can predict which lesions are less likely to heal and which lesions we need to be more aggressive with. So our treatment, initial treatment, if you have an OCD lesion where the articular cartilage is intact, so a Hefty stage 1 or 2 lesion, our initial treatment is non-operative because these lesions can heal. Non-operative treatment has meant different things. Certainly it means activity restriction, so we stop their running, jumping, and their impact. Protected weight bearing with crutches, I'll typically use that if they're limping just to get them over their limp. We tend not to immobilize these because we think motion is good for the joint. And we're interested in, we've been looking at using an unload or brace to take pressure off these lesions to see if they will heal at a higher rate or heal more quickly. And the length of treatment can vary anywhere from 3 months in the literature up to 12 to 24 months, but usually we're trying non-operative treatment for 3 to 6 months. Non-operative treatment can work. This is a patient with an OCD lesion treated with activity restriction and an unload or brace, and 3 months later the radiographs are normalizing. Similarly, this is a different patient, but the MRI showing the OCD lesion, 3 months of non-operative treatment showing less demarcation and healing of the lesion. The problem, though, is that not all the lesions will heal. So even with Cahill and his study, with 10 to 18 months of restriction of sports and protected weight bearing, found that about 40% of these did not heal with non-operative treatment. The length of treatment can become difficult. These are often kids who are very athletic and active, and so it's hard to keep them out of sports for 6 months, and they've got a 40% chance it won't heal. Then they need surgery, and then they're out again another 4 to 6 months. So that can be very difficult. And during this time of non-operative treatment, they can get older, approach skeletal maturity, where we think that their healing ability is a lot less. So we're trying to figure out which lesions will heal and which lesions won't heal. What are some of the predictors that we think may be related to their ability to heal with non-operative treatment? So certainly whether they're skeletally mature or not. So if their growth plates are closed, we think they have less healing ability for OCD. If they're younger, they have a greater healing ability in general than older patients, even if their growth plates are open. The size of the lesion, so smaller lesions more likely to heal. The location, the classic location, medial femoral condyle, seems to heal better than patellofemoral lesions or lesions on the lateral condyle. And the chronicity of their symptoms, if they've been having symptoms for years, less likely to heal with non-operative treatment. We looked in this with a prospective multi-center comparative study that we presented last year at AAOS. So we had patients who had juvenile OCD of the knee with a stable lesion, and they were treated in 3 arms. They all had activity restriction and physical therapy. This arm had that alone. This arm additionally had casting, and this arm had unloader bracing. And our study population was 123 knees in 114 patients, and 112 knees in 103 patients met our criteria. The mean patient age was 11.6. Most lesions, about 84%, were on the medial femoral condyle. And again, these were lesions with an intact articular cartilage, so lesions that were stable, not unstable lesions. And our flow chart is shown here. All patients were seen. They had initial evaluation and MRI scan. They were treated with non-operative treatment, and then at 3 months they had a follow-up MRI scan. If the lesions were healing, then they returned to activities if they were healed. If they were healing but not healed, then we kept them with non-operative treatment. And if their MRI follow-up looked worse or no better, then we proceeded to operative treatment. So that was our flow chart. What we found was that overall healing rate was 62%, which is very similar to Cahill's 60% healing rate. And we found that the predictors of success with non-operative treatment were age, so older patients did less well, lesion size, larger lesions did less well, more chronic the symptoms, they did less well, and if they were a stage 2, a demarcated lesion compared to a non-demarcated lesion. What was very interesting was we saw a strong trend. It didn't reach statistical significance, but a strong trend to a higher healing rate with unloader bracing. So 71% of those lesions went on to heal, compared to activity restriction alone, 60%, and casting, 53%. So we're now repeating this study in a larger patient population with more power to see if unloader bracing truly has a higher healing rate. But my clinical sense is that it does. Eric Wall from Cincinnati Children's Hospital published a similar study in a smaller patient population, 47 knees in 42 patients, and they found overall similar results. So 66% progressed towards healing. They also found that age, size, and the length of symptoms were important factors. So we're seeing a convergence around 60% or so of these lesions will heal with non-operative treatment. So that brings up what are our operative options, so what are surgical indications. So we treat these lesions with surgery, certainly initially if they're detached or unstable types of lesions, or those lesions that have intact cartilage that failed non-operative treatment that we just talked about. If they're skeletally mature, we'll usually go to surgical treatment as well because we think they have a much less healing ability. What are our surgical options? They're shown here. We can drill lesions, we can fix lesions, we can remove OCD lesions, and we can do chondral resurfacing. So these are our surgical options. And drilling, the rationale is to increase vascularity and cellularity. So we'll typically do these for lesions with an intact articular cartilage that failed non-operative treatment. And we can either drill through the articular cartilage, so transarticular, this is a 0.045 millimeter C-wire, making multiple perforations through the subchondral bone into the normal bone, or we can drill without going through the articular cartilage, so retroarticular drilling through the epiphysis using fluoroscopy, and both techniques have shown high healing rates. This was a series we published on 30 knees, 23 patients we treated with drilling. They all failed non-operative treatment, had an intact articular cartilage, and we found that they all went on to heal, typically at 4 months to 5 months after their drilling. And other series have shown similarly high healing rates. Fixation of the lesion. So why would we fix a lesion? That's to give it, treat it kind of like a fracture, to give it stability so it can go on to heal. We're often drill in addition to fixation. And we can try to fix these lesions from behind the lesion. More frequently, we go from the articular side, and there's a variety of hardware that can be used. So wires, screws, variable pitch screws, now bioabsorbable variable pitch screws, and bioabsorbable tacks. We published a paper recently where we looked at 26 knees in 24 patients with juvenile OCD, 4.3-year follow-up, and these were all unstable lesions. So they were fissured, partially attached, and we had 6 actual loose bodies in the knee that we put back and fixed. We had a variety of different hardware we used to fix them, and what surprised us was that there was an overall pretty high healing rate. So 85% of these went on to heal, including the 6 lesions that were loose bodies, that were unstable lesions in the knee. And our take-home message was, it's worth, in these younger patients, giving it a try with fixation to heal, because if it does heal, then they keep their own articular cartilage, and we're not in the situation of excision and chondral resurfacing. So we're pretty aggressive with trying to get these to heal. What about excision? I think sometimes we do excise the lesions because it's often for detached lesions that are chronic, because the articular cartilage on the lesion will be poor, the bone quality will be sclerotic and poor. The piece may have grown in the joint, so it no longer fits where it came from, and so sometimes we have to take these out. If they're smaller pieces that are away from the main weight-bearing articular cartilage area, taking them out is a good thing to do, and they have a good long-term prognosis. The problem is that many of these lesions are big and they're in the main weight-bearing area, so if we take them out, they're at high risk to develop arthritis in their knee in 10 years, and that's what Alan Anderson has shown. So when we excise these bigger lesions in the weight-bearing surface, we then have to do chondral resurfacing types of techniques. And the chondral resurfacing here is a bit of a challenge, I think, more than just chondral resurfacing, because we're not just dealing with a articular cartilage defect, we're dealing with a cartilage and bone defect. And so our options in the human are mosaicplasty, where we take plugs of bone and cartilage from elsewhere in the knee, but there's some donor site morbidity. These lesions are often pretty big, so you have to use multiple plugs, and you get cobblestoning. We can do osteochondral allografts, so fresh osteochondral allografts, which we've been doing more and more of, and autologous chondrocyte implantation, but this may have to be done as a staged procedure where you bone graft, then come back and do ACI, or you do a sandwich type of ACI where you treat the bone and the cartilage at the same setting. This is just an algorithm showing that approach. So we'll move next to deformity, and then I think we can do some questions, give you some thoughts and conclusions. So I wanted to talk a little bit about our management of deformity as well, because we're treating largely patients who have open growth plates and are still growing. And we see different types of deformity. We see angular deformity, rotational deformity, and leg length inequality. So leg length inequalities are actually probably very common. If you ask the tailor about human leg length, so often say one leg's a little bit different than the other. Small leg length differences up to about 2 centimeters or an inch really are pretty frequent, and they're not associated with long-term problems. So we really ignore small leg length differences under 2 centimeters. We can see once you get above an inch or 2 centimeters, we can start to see secondary problems: back pain, hip pain, leg pain, patellofemoral pain, scoliosis. So we're largely treating leg length differences greater than 2 centimeters. We evaluate these clinically by measuring with a tape measure or putting a block under the short leg and measuring the top of the iliac crests. And you can see what size block balances the iliac crests. So that's how we're measuring them clinically. Radiographically, we have different techniques for measuring the leg lengths. We typically use a scanogram, or now CT scanograms are pretty popular. So these are x-rays of the hip, knees, and ankles with a ruler, and you can measure out the lengths of the different bones. And so we can see what the leg length difference is. This is an example of a leg length difference in a patient with neurofibromatosis type 1, where they've got a left shorter than right leg length discrepancy, and there's a bone lesion from neurofibromatosis there as well. And so we can measure these out. What's important for us is to predict what the leg length difference is going to be at skeletal maturity, because that determines what our treatment is. We can do this in a variety of ways. So we have a rule of thumb method where we say girls typically end growth at 14 years old, boys at 16 years of age. We know how much growth is coming from the different physes in the leg, the proximal femur, proximal tibia, distal femur. So if they have a problem with one growth plate, if it's a 12-year-old boy who's got a distal femoral growth arrest, we can just, rule of thumb, say he's going to grow for 4 more years at about 1 centimeter a year. He's going to end up with a 4 centimeter leg length difference. So that's kind of back of the envelope type of calculations. There's ways of doing this from growth tables, looking at the amount of growth that they have remaining. This is a straight line method that uses growth tables and is more accurate than the back of the envelope calculation, and a multiplier method Dror Paley developed that also uses growth tables. So these in general are more accurate, and now we have these on the computer and even on apps on your iPhone. So we can try to determine, based on what their leg length difference is at multiple points in time and where they are in terms of their skeletal age with their growth, we can figure out what is the predicted discrepancy at skeletal maturity. What are our different treatment options? If we have a young patient that has a focal growth arrest, so they've got a growth disturbance across their growth plate, which is less than 50% of the growth plate, and they have at least 2 years of growth remaining, we can try to excise that physeal bar. So we typically come from the metaphysis using imaging, and then we excise the bar with curettes and burrs, and then we fill that bar with soft tissue to try to get the growth plate to grow with variable success. Probably about 2/3 of these will be successful, 1/3 are not. Then we're left with our traditional treatment. Again, 0 to 2 centimeters, we don't do much. If their predicted discrepancy is 2 to 5 centimeters, we usually do an epiphysiodesis, where we stop the appropriate growth plate on the long leg so they end up with the right leg length at the end of skeletal maturity. If they have a predicted leg length discrepancy of 5 to 15 centimeters, then we're usually talking about lengthening types of procedures, so distraction osteogenesis. And then if it's a big discrepancy over 15 centimeters, then that's going to involve multiple lengthenings, perhaps epiphysiodesis on the long side, and if they've got a bad deformity, sometimes amputation and prosthetic fitting. So that's for leg length discrepancies. The other discrepancies, growth issues that we see, are angular deformities, and this can be challenging because as children are growing, they're changing in their coronal plane alignment. So most children are bow-legged, they're varus up until about age 2 or 3, and then they become valgus, and then they assume their adult coronal plane alignment. One of the angular deformities that we see is called Blount's disease, and so Blount's disease is a genu varum, a bow-leggedness, and it's an issue with the medial proximal tibial physis. Typically we see this in heavy kids or kids with a disease of their proximal medial physis. We see infantile Blount's in young kids 1 to 3 years of age, and adolescent Blount's in kids who are 9 to 11 years of age. And they'll have a pretty characteristic deformity. So it doesn't look like physiological Blount's. It usually involves one limb, not the other limb. And they'll have this characteristic deformity of the proximal tibial metaphysis and the proximal tibial physis. So we have to separate that from physiological bowing. Sometimes you can have bilateral Blount's disease, but again, the deformity is usually more severe, and you'll see this diseased metaphysis and physis in the proximal tibia. We evaluate Blount's disease usually with radiographs, and we have different angles that we measure to tell us what the severity of the Blount's disease is. And again, it's often easy to distinguish from physiological genu varum, and we can see recurrent deformity even after our treatments. So our treatments for Blount's disease are typically, we can try hemiepiphysiodesis, so we stop the physis on the lateral side of the tibia to try to get the medial side to grow. And that has variable success because the physis on the medial proximal tibia is sick. And so we have to evaluate that physis, usually with MRI and the severity of the deformity, to see if hemiepiphyseodesis will work. In more severe deformities, it usually doesn't work, such as in this case where it didn't work, and we have to do an osteotomy, so where we cut the bone in the metaphysis to realign the leg. The other deformity that we see, angular deformity, is genu valgum. And genu valgum can either be physiologic or it can be pathologic based on its severity. Unilateral genu valgum is often pathologic. We can see this secondary to fractures where we get an overgrowth on the medial side of the physis and an undergrowth on the lateral side. So if this is mild and physiologic, we usually don't do anything. We don't typically brace. And if it's severe, we can treat this with hemiepiphyseodesis or surgery. So these are our two major options. So hemiepiphyseodesis, where we stop one side of the growth plate to correct the genu valgum, or if there's insufficient growth for that, or if the severity is too severe, then we'll typically do osteotomies. And it can be a challenge to go from valgus to varus because you're putting a stretch on the peroneal nerve at the knee, and they can get nerve dysfunction. And then we see rotational deformities are very common. And so we'll see parents bringing in their kids because they into, and they really can into because of one of three reasons. In babies, it's usually because the foot itself is curved in, a bean-shaped foot, metatarsus adductus. In toddlers, it's usually internal tibial torsion, so the tibia is inwardly rotated, and that usually corrects on its own. And then in older kids, we usually are seeing femoral aneurysm, where they have increased internal rotation at their hips and decreased external rotation. And we just evaluate this clinically. Many of these we don't do anything for because they will heal on their own. If they are now older and they still have severe intoing, then we may need to do osteotomies where we cut the bone and change the rotational alignment, but that's very, very unusual. So I thought I'd show you some cases. This was a 12-year-old with knee pain and genu valgum, and her bone age was 12 years of age as well. And so we did a medial hemiepiphyseodesis. So we used to use staples a lot, now, but staples can back out as they grow. So typically now we do these plates, 2-hole plates, on the medial distal femur. So we're doing a hemiepiphyseodesis the medial side of the distal femur, so the lateral side will continue to grow, and if they have enough growth remaining, we can get correction. So this was 1 year later at 13 years of age, and now her bone age is 13 and a half, so she's got about 6 months of growth remaining. But she went from painful knees with genu valgum to a much straighter alignment with resolution of her knee pain. Here's another example of hemiepiphyseodesis. And so this is a patient, again, with leg pain, genu valgum. When we draw our mechanical axis, which is a line from the middle of the hip, the femoral head, to the middle of the ankle, the middle of the talus, in general, we want this line going through the middle of the knee. And you can see here how the line is actually on the outside of the knee. And so mechanically, that's going to load the lateral side of the knee, and they'll be at risk for lateral knee arthritis and other problems. If they're skeletally mature, the only way to address this is with osteotomy, so cutting the bones and straightening the legs. Again, if they have enough growth remaining, we can do a medial hemiepiphyseodesis with these plates. And then this is about 1.5 years after surgery, and that mechanical axis, which went from lateral to the knee, is now more towards the center of the knee, and there's some growth remaining, I think, for future correction. This is a patient we just got sent to us for a meniscus transplant. This patient is 19 now, and he had a discoid lateral meniscus, and after a couple of surgeries, eventually had his whole lateral meniscus taken out. So he's got no lateral meniscus. He's got lateral knee pain, swelling in his knee, and early articular cartilage loss. So this knee is heading for problems. This is the MRI showing a medial meniscus, and there's just no meniscus here between the femur and the tibia. And again, this is a sagittal MRI. He's got a little bit of an anterior horn of lateral meniscus, but no body. It's all taken up by articular cartilage. And so we scoped him. This was his lateral compartment. Again, no meniscus. You're seeing just the tibial plateau and the femur above. and he's already developing some articular cartilage defects on the tibia and on the femur as well. But an issue was his alignment, and so this is his knee. He's got no lateral meniscus, but he has substantial valgus alignment as well. And so if we did a meniscus transplant in this patient who has his mechanical access is already going through that lateral compartment, there's a higher failure rate. So we needed to stage him and do an osteotomy. So his deformity was mostly at the femur, and so we're doing an incomplete osteotomy where we're putting a guide wire across the metaphysis at an angle. We then start to open up this osteotomy, and we're opening it up progressively until we get that correction. So this is the line from the middle of the hip to the middle of the talus, and that was over here, and now we've corrected it just medial to the tibial spine. So that's the amount of correction that we want. And then we went ahead and fixed this with a step plate and bone grafted. And this is a recent x-ray. I think he's at 6 weeks and he's showing a lot of healing. So he'll get a staged procedure to correct his alignment to unload the lateral compartment and then a meniscus transplant. Here's a case of Blount's disease. And in this case of Blount's disease, the physis, there's not as severe deformity, and the MRI showed that the medial proximal tibial physis still looked relatively healthy. So in this situation, we can do an epiphysiodesis, hemiepiphysiodesis on the lateral side of the proximal tibial physis, and then this went on to good correction. And then theoretically, if we're corrected and they're still growing, we can take these plates out, and hopefully they grow straight. If they get recurrent deformity, then we may need to do it again. If we don't take the plates out, they may actually grow into genu valgum, into being knock-kneed. And then, again, sometimes if they're older kids or that physis is sick, then we can't do a hemiepiphysiodesis, and so we have to do osteotomy. For Blount's disease, I like to use external fixation, and we can do an acute correction. So these are 2 ringed fixators, and then we do our osteotomy at this level. And you can see the angle of these fixators and the angle of the leg. And then we do our osteotomy. We cut it. This is an acute correction where we're holding it with struts. And we've straightened out the leg. Now, if we are doing a huge correction, then we may want to do this gradually, a gradual angular correction instead of an acute correction. And it really depends on the amount of deformity. And some of these can get very complex. So this was a deformity that we did, which was a 7-year-old child with fibular hemimelia with already a leg length difference of 2 inches and a foot deformity associated with her fibular hemimelia. So here is her leg. She's got a short lower leg with this foot deformity. And she has a good enough foot to save. In some of fibular hemimelias, we do an amputation and we fit them for a prosthesis. But she had a good enough foot to save. These are her preoperative x-rays showing her deformity. So in this, we did a gradual correction with a talar spatial frame. So this is her frame where we've done an osteotomy in the tibia and an osteotomy in the foot. And we're going to gradually correct this every day using the computer. This is what her x-ray will look like. We had postoperatively some issues with her pins in the foot migrating and her actually tampering with the struts. And so we took the pins out and we placed static struts instead of dynamic struts that we had to correct on our own. And then this is the frame, again, pre and post. And then here's her leg pre and post. So again, a short leg with her foot deformity, and now we have her leg out to length with a more plantar grade foot, better alignment of the foot. And we were able to accomplish that with gradual lengthening. And so here are her x-rays pre and post showing the regenerate and the lengthening of the tibia. And then there she is clinically. Other growth problems we see can be iatrogenic. And so this is something, we do a lot of ACL reconstruction surgery in kids with open growth plates. And how we reconstruct the ACL with respect to the growth plates is a matter of debate. We've developed a procedure where we can do an ACL reconstruction without drilling across the growth plate, but you can see growth disturbances after ACL reconstruction. This was a kid that had relatively normal alignment. He's 14 years old, so he has about 2 years of growth remaining. He was treated with an ACL reconstruction that went across the growth plates. So it went across the growth plates, and the fixation was kept away from the growth plates, and allograft was used. And so here's his initial fixation. So he's got a tunnel going here and a tunnel going here, fixation away from the growth plates. But the problem is he went on to his graft failure and a valgus deformity of his knee. And so here he is now, and this is 10 months after his initial surgery, and he's got a valgus deformity of the knee, which looks bad clinically, and a failure of his ACL, and he's got about a year of growth remaining. So we treated him with a revision ACL reconstruction, and we did a medial distal femoral hemiepiphysedesis to address his valgus deformity. This was a case that we saw was a young child, so a 10-year-old. In the 10-year-olds, we usually don't do a reconstruction across the growth plates. This kid had a reconstruction across the growth plates done elsewhere with hamstrings, and now he shows up at age 16 to us with an unstable knee and substantial valgus deformity of his leg. So you can see this valgus deformity of his right leg. And when we looked at it with CT scan, his proximal tibial physis is open, but there's an arrest of the distal femoral physis. And in addition to his angular deformity, there's been a decreased width of development of that distal femur. But there's his growth arrest across the distal femur, but open on the tibia. Now, he doesn't have enough growth remaining at age 16 to try any sort of excision of a bony bar or even hemiepiphysedesis. And so he was treated with staged osteotomies of the femur tibia and then ACL reconstruction. So in conclusion, again, I thought it'd be really interesting to talk about these areas where we may overlap, not just from a research point of view and translational research from animals into humans, but from a clinical point of view, because I know that you treat osteochondrosis and deformity as well. I think for those of us in human sports medicine, we look a lot to what you're doing with stem cell injections and treatment of some of these injuries in terms of how it may be applicable to humans. And I think this dialogue and interaction is very helpful for us both. So thank you very much, Wayne, for the invitation, and thank you for your attention.